Good afternoon, everyone, and thank you for attending today's webinar, Testing for COVID-19 COV2, the Novel Coronavirus and Evolving Guidance in Testing, presented by Nick Melchiori, General Manager of Accurate Diagnostic Labs, and Dan Fabius, Chief Medical Informatics Officer for Consensus Health. Please be aware that there will be a question and answer portion today at the end of today's webinar. Please type your questions in the question box located on the right of your screen, and they will be answered in the order received. Additionally, if you would like a copy of the presentation slides, you can find them in the handouts section on the right of your screen. They will also be emailed to all participants following the completion of today's webinar, as well as a recorded version will be available on the website for members only. Again, we would like to thank you all for attending, and I will now turn things over to Nick and Dan.
Just taking myself off mute here. Hi, my name's Dr. Daniel Fabius, and as I was introduced, I am the Chief Medical Informatics Officer for Consensus Health. We are a 50 doctor medical group trying to help keep independent doctors independent. Nick?
Good afternoon, everyone. Nicholas Melchiori. I'm the General Manager of Accurate Diagnostic Labs. We're the largest privately held commercial clinical laboratory in the region, and we perform clinical pathology, virology, molecular, and genetic medicine. I'm a 25-year veteran of the laboratory coverage policy, molecular, and development space. Also a member of the National Business Group on Health Disease Management Association, former member and founder of both the National Association of Quality Ancillary Providers and member of the Long Island Healthcare Task Force. Thank you, Dan.
So just a brief overview here. So coronaviruses are a large family of enveloped viruses with a single strand of RNA. You'll see a picture of the one on the right. What we currently know about this version of coronavirus is that it attaches to the ACE2 receptor inside of the lung, and that's how the RNA gets inside of our cells. This family of viruses cause a large range of illnesses, things being a common cold or upper respiratory infections to very more severe disease like Middle Eastern respiratory syndrome and severe acute respiratory syndrome. They come from animals. They can be exchanged from animals to people. And in fact, it seems that MERS, SARS, as well as the current COVID-19 all seems to have a bat origin originating inside of China. For this disease that we're going to be talking about today, COVID-19, we are focusing on the symptoms of respiratory, fever, cough, shortness of breath. Why are we focusing on those symptoms? The overwhelming majority of people early in the disease, based on the current literature that's been published, develop those symptoms in the very beginning. So if a person has one of those three features, it's very likely that that is a symptom, possibly. Now, many other diseases cause lots of these symptoms, but we're just talking about how do we get into screening. So, like we just talked about, they need to have a symptom plus a risk factor. The risk factors are changing every day. Nick is going to talk about how even on Friday, they changed those risk factors as well. So last week, that was high risk countries. Now it's community spread. And you have to realize if you're in a county who has ongoing community spread, because that is a risk factor. So if someone has symptoms and you're in a community with ongoing spread, like the outside of New York right now and the outside of Philadelphia, specifically Camden County, we're seeing rising spread. We expect that to spread to the rest of New Jersey over the next couple of weeks. So be very cognizant that you should be on increasing your risk factors or your screening protocols and making sure that you are identifying more and more patients as possibly having the disease. That's why we are also recommending if you can do telemedicine. I always remind my doctors in our practice that the phone is a form of telemedicine, it is synchronous telemedicine. Get on the phone with them, talk to them, have your staff talk to them, screen them on the phone. Place a sign outside the door before they come in. Send communication out saying that if you have these symptoms, call us first. Let's talk to you. Let's figure out if this is the right thing before they come into your waiting room. If you have an audio and video platform like we just set up for our medical group, as of Friday we set it up, you can bill telemedicine. Most major payers are saying that they will reimburse for this. We all know it's going to be more complicated than that. We all know that the payment cycle is not easy, but that is the promise that Medicare, United, Aetna have put out into the community. It's to get reimbursement, for Medicare, you need to put place of service 02. So if you have an RCM company, make sure that they're changing that, make sure you're identifying that. We are also recommending to our doctors to use modifier 95. That's really for the commercial insurers. We're probably going to get denied initially from Medicare, have to remove the 95 modifier and resubmit. We prefer to make sure to standardize our approach by making sure everyone has place of service 02 and making sure we're using modifier 95. We know that modifier GT exists. We're not going to be using that in our medical group, but you need to talk to your RCM company about the approach they want you to take. Let's talk about disaster recovery plan, infection control. So the big thing about infection control is hand washing. 20 seconds of hand washing with soap and water is necessary before and after every patient, every time you're interacting with someone. Or using alcohol, at least 60% with moisturizer for 15 seconds. The World Health Organization has a video online to review proper hand washing technique. This is nothing new. This is a thing that we all have been trained to do for a long time. It's something that we need to be even more hyper vigilant about currently. When it comes to surfaces, if you have alcohol wipes, 70% or more, or bleach wipes, you should be using those on as many surfaces you can as regularly as possible to make sure you're cleaning anything out, especially if for some reason you miss a screened patient who comes in sick, who you've identified. Get that person out of your waiting room as quickly as possible. You can determine if you want to send them back to the car, if you want to send them to your exam room immediately, but get them out of your waiting room and clean all the surfaces. If you have an exposure.
Say, Dan, just one note for everybody. If you're using an alcohol solution or a bleach solution, this is something that we're all common with. We should all have an OSHA hazard guide in our standard operating procedure, and we should all be following that closely as hazardous materials, and we should have an eye wash station somewhere available to our staff. Thanks, Dan.
And again, if you guys have exposure, make sure you take your exposed staff to a positive laboratory confirmed case and make sure that staff gets self-quarantined. We're going to talk about in a second how the government is going to help your businesses about that too. Testing criteria, again, constantly evolving, constantly changing. So you can always call your local health department to determine if the person meets the current testing criteria, but you need to have a symptom plus a risk factor for this person to be. Testing is not the immediate priority. The turnaround time for testing is taking close to 5 days. Now that's going to change in the next week, next 2 weeks. Nick is going to talk to you about how the testing is going to change, the availability of testing and the turnaround time. The health systems are all getting up and running, accurate labs getting up and running. There's going to be a much more local presence to turning around that, and there's going to be drive-through. But it's also very important to protect yourself. So if you don't have a test kit, don't try to find one. Get the person, if they have mild and moderate disease and they're not having any shortness of breath, get them home, have them stay home for 14 days, self-quarantine. Same thing with your staff. If you have questions about if you should test somebody or not, call your local health department. It's more important to make sure you're up and running so that you can answer these patients' questions and take care of those well people than to test someone urgently. So last slide from me before I hand this over to Nick is to talk very briefly about the Family First Corona Response Act. This was literally signed into law on the 14th. A lot of things changed on Friday, why we're having this presentation on a Monday. Try to get people back up to speed with the rapidly changing information. Don't be afraid to send your employee home. If you've got to work on a selling crew, I know this is going to tire us all out. The more ambulatory clinics that are open to answer questions and to help people, it's going to help all the surrounding health systems. The more that we're there and available, people, I will be seeing patients myself at 3 p.m. today, happily and proudly. Protect yourself and answer questions. Use telemedicine. And if you got to send someone home, send them home, because the U.S. government says that they're going to protect our businesses. Emergency Paid Sick Leave Act is number E on that slide there. You can look through all the things this is going to offer your businesses. That's what the federal government's saying. It's important that we remain available for our patients. If it's by phone, it's by phone. If it's audio video, it's by audio video. If they're well and you want to see them in person, even better. Nick, I hand it over to you. Nick, I don't know if you're on mute.
Thank you, Dan. Next slide, please. Okay, so today we're going to discuss about the coronavirus, what the testing that's available, the deployment of the testing, and where it's appropriate, and some of the performance and characteristics of the test that we know so far, and where we've come in a short period of time. So the coronavirus test is not for SARS-CoV-2. It's being referred to as COVID-19. COVID-19 is the disease associated with the SARS-CoV-2 virus. There is a COV1 back from the early 2000s, SARS test that we have, and there's 4 other coronaviruses that we routinely test for. The thing that's important to remember is that as practices order out of their systems your electronic medical records, your paper records, you're going to have existing tests for coronavirus, for flu, for respiratory pathogen panels that do not test for SARS-CoV-2 being labeled as COVID-19. So if you do place an order and it's through an electronic medical record and you handwrite in COVID-19, we're going to have a lot of issues with the ordering and resulting of these samples just due to how automated testing is. And there are 4 other tests specifically for corona that are not for SARS-CoV-2. There are 3 options right now for the coronavirus SARS-CoV-2 test. Those are that are already commercially available. One is the China CDC primer and probe set. The second is the United States Center for Disease Control primer and probe set. And the third is the non-CDC primer and probe set. The reason these are important is that as manufacturers bring up availability of testing across the country, we have 4 coronavirus tests that already exist, along with the flu and a slew of 30 plus more respiratory pathogens that we look for. And when we look for these, we're pulling apart the RNA from the DNA, and we're looking for a subset in the N and P region of that RNA that is indicative of the virus that we're looking for. So we have to do in silico analysis to rule in inclusivity and cross-reactivity to other viruses. This is evolving. It's definitely fluid, and we're going to learn a lot more as these assays come to market. Next slide, please. How do I collect a COVID-19 test? We've received a lot of requests about this. So the preferred sample is frozen. Not a lot of people have access to freezer packs or dry ice in their practice. And not a lot of practices have access to PPE. So we're also seeing a major shortage in nasopharyngeal swabs and PPE. So what I would suggest is that if you do have an infection control policy and disaster recovery policy in place that you can transfer patients, if your office does have to go under self-quarantine, follow proper doning and donning of PPE. That's very important. There's a face shield and there's a N95 mask associated with that, and the changing of gloves and wiping down surfaces between each patient. A nasopharyngeal swab and oropharyngeal swab are the preferred specimens along with sputum. We do need to freeze these samples. As Dan mentioned, turnaround time right now is fluctuating between 3 to 10 days as assay availability comes up and running across the country for laboratories. That will shrink. However, it is quite common in the laboratory industry when there is a flu epidemic or a spike in an epidemiology event to have a backlog on reagents, calibrators, controls, extraction devices, which are all needed to perform this testing. So we need to be conservative with who the appropriate people are to use this test. The final note on this slide is that we need to use caution when interpreting the results of this test. The value will come out in your EMR or on paper as detected, non-detected. And it's important to note the comment at the bottom of the report. It will say that these tests have not been evaluated by the Food and Drug Administration. You should not use these tests in the diagnosis, treatment, or cure of a patient, and that's because they have not been evaluated by the FDA. Next slide, please. So what should we tell our patients? The first thing that we're hearing from our payers and from the Department of Health is to stay home and self-quarantine. This is a very evolving criteria. The initial CDC guidance that came out of level 2 or level 3 countries with symptoms has been changed and is outdated. The direction of direct contact with a person who's confirmed of a person under investigation has changed from the CDC. And on March 14th, we got new guidance. And the guidance states is this, I'll read it verbatim. If you are in close contact with someone with COVID-19, or you are a resident in a community where there's an ongoing spread of COVID-19 and develop symptoms of COVID-19, call your healthcare provider and tell them about your symptoms and exposure. They will decide whether you need to be tested, but keep in mind that there is no treatment for COVID-19, and people who are mildly ill may be able to isolate and care for themselves at home. The screening criteria goes on, and our guidance from our managed care payers and local health departments has been to screen patients and essential health workers for COVID-19 who are greater in years of age of 65, are immune compromised, i.e. diabetes, heart disease, receiving immunosuppressive medications, chronic lung disease, chronic kidney disease, or underlying respiratory conditions. Next slide, please. A question we're getting quite often is the test available? Can I send a test? This is being mitigated by a couple of factors. Lack of access to PPE and collection locations is a major factor, along with lack of access to nasopharyngeal swabs. So the nasopharyngeal swabs are manufactured primarily by Copan out of Italy, and we're seeing a backlog, we're being told, to mid-April or May. BD has committed to bringing up manufacturing here in the States, and we're waiting for further guidance. You may see in your office a UVT That's a universal viral transport or a universal media transport. These have red caps and purple caps. And if you have a nasopharyngeal swab, they must be placed in that media, in the universal viral or universal multi-purpose media. If they're not, it will be cause for rejection. If you're using a wood stick cotton swab, that's cause for rejection. And if you reach out to your local laboratory, they can give you a full list of causes for rejection. The big one being we really need to freeze these samples since by the time they get to the lab, with a shortage of staff at all laboratories across the country due to absenteeism and due to the increase in this testing, we are concerned about the stability if the test is not frozen. Next slide, please. In the past 2 months, we've had a deployment of assays. So the CDC first brought up the SARS-CoV-2 assay on January 5th. The State Department of Health deployed their test kits on February 17th. They were in limited supply, and until that point in time, up until March 5th, most of these tests were being dedicated to Seattle and California, where the majority of outbreak was, to try and quarantine those affected. On March 5th, Laboratory Corporation of America did an amazing job and brought up the first commercial assay available in the country. This was under emergency use authorization. And similar to LabCorp, on March 13th, the United States FDA waived some of the conditions that all labs are under that will allow us to perform this testing. So up until March 13th, our national labs, our hospital labs, were all using a much slower method for running testing. As of March 13th, all of us labs across the country that have access to this high throughput automation have started to stand up the assays, but there is a little bit of work to do still to get us all at capacity. And we think that by the end of this week, across the country, we'll be north of 50,000 samples a day and well within to a 200,000 sample per day mark.
It seems we have lost Nick. Dan, are you still there?
Well, I think. Can you hear me?
Yes, I'm back. I'm sorry, my call dropped. Can we move to the next slide, please? Dan, are you able to move to the next slide? Perfect. Yes. One of the comments that we've received a lot of questions on is, will this test detect active infection? How do we know it's an active infection? How do we know that this is not a recurrence? We don't necessarily know how well this test is going to perform or the performance and characteristics of the test. There are many manufacturers pulling raw materials from many different places, and with all assays, there are concerns about pre-analytical, analytical, post-analytical processes. I would say use caution in the use and interpretation of these tests. Next slide, please. What should we use to order the test or with an office visit? So We've had direct contact with all the national payers, and our local payer published information about Horizon about the use of code Z208.828. This is contact with and a suspected exposure to other viral communicable diseases used for cases where there's an actual exposure to someone who is confirmed to have COVID-19. This would be the appropriate code to use when screening a patient. In addition, we're going to need to put a secondary code on the diagnosis: cough, shortness of breath, fever, other viral pneumonia, acute bronchitis, bronchitis not specified, other specified respiratory disorders, acute respiratory syndrome. You're going to need to put something other than B34.2. Do not use B34.2 because this is not COVID-19. B34.2 is used for unspecified. COVID-19 is the disease, it is specified. So that was called out very clearly to us early on by our managed care partners. Also, do not use the code U07.01. This was the ICD-10 code published by the WHO for use for COVID-19. This ICD-10 code will not be available until October 1st, 2020. We must use the codes that are available to us. It's really uncertain how coding and payment policy will be used, but we are assured that as long as we're using the CDC criteria, this testing will be covered. And there's some significant changes that came out Saturday morning, in the early hours of the morning, with the FFCRA. We're doing our best to read through that material, and we will be disseminating information as it becomes better understood. Next slide, please. So the question continuously comes up, what's this going to cost? Is it true that this is free for everybody? We know that what we know is very limited and very early. The Medicare published fee schedule for this is $51.35. I can say with confidence that anyone who is charged an amount greater than $51.35 should not be. And this is the general guidance that all labs have committed to accepting this as payment in full without a copay. So all copays under the FFCRA have been waived for the testing. As far as commercial insurance and Medicare codes and how that'll play out after the pandemic crisis is lifted, we're still not clear. What we are clear on is this is changing and dynamic. We're going to have to learn together, and we'll do our best. Next slide, please. We'll go through these really quick and then open it up for questions. So who should be tested? Follow your CDC guidelines and contact your local Department of Health. They're going to be the best to give you the most up-to-date information on CDC. And CDC is the one who we're following for guidance on, is the test going to be covered? Will a patient service center or phlebotomist collect? No, only a healthcare professional can collect and should collect, and only with the appropriate PPE and infection control policy in place. How do I access testing? Contact your local health department. We do have the list of local health departments by county and their county office numbers. I can tell you that we've been in direct contact with the state, the governor's office, and the local health departments for the better part of 2 weeks every day. Their phones are inundated, so you're better to call your local Department of Health. They can give you the best information. What is the expected turnaround time? Based off of what we can understand from our laboratory partners, we're all expecting 24 to 72 hours with automation. As the month of March and April progresses, we think we'll be able to live up to that. But I would expect between 5 to 10 day turnaround time in these initial days as availability comes up and running. I think if anybody tells you something differently, keep close track of turnaround time, and we're all working together to identify availability with sources Pretty much every lab in the country is working on bringing up this test. There's 327 million Americans. That's a lot of people to be screened, which is part of the FFCRA. We will do our best to get this up and running as quickly as possible. And then the last question that I get a lot is, if I test negative, is it truly a positive, or is it truly a negative patient? Well, not necessarily. The performance characteristics of this test have not been evaluated. The viral strains that are here, coronavirus mutates, and there's a new coronavirus that comes out quite often. This is a very specific one that we're testing a fragment of RNA for. And the performance characteristics are going to depend largely in part of the source manufacturers. So that are the suppliers that supply the manufacturers. So first, we need to create primers and probes. We need to create extraction kits. We need to create control material, and then that goes to the manufacturer. They package it together. There is a run on this material. So whether we're looking for a test from Roche or Abbott or Hologic or PerkinElmer, they're all sourcing from the same place, and a lot of these materials come from China, and there's a significant shortage on them. So we're all working together. Next slide. If you have questions, we recommend that you reach out to the World Health Organization. The CDC is the best place for this information in the pandemic. The New Jersey Department of Health has a hotline that you can call. What I found most helpful and what the governor last night said on his conference call is to go to your local Department of Health. If you need the local health department phone numbers, we have a PDF with all of their email addresses and phone numbers that we can send to you. Next slide, and let's open it up to questions.
Okay, thank you. So now we can do some questions. If anyone has any additional questions that are not already in here, you can type them in the question box located on the right of your screen. So the first question we have is, what telemedicine platform did you put in place for your physicians?
Can you hear me? Can you hear me?
Yes,
I'm sorry. Good. I'm having a little trouble with my mic. So that's a great question. It depends on the EMR platform you're using. One free option that's very easy to implement for an independent practitioner, I believe that's what we have on the phone call, is Doxamy, DOXY.me.
I'm sorry, it's actually really breaking up. We cannot hear at this time. Nick, are you able to answer?
If there are questions that we're unable to answer, please feel free to email Brea or Dawn, and we'll send an email back out to them. Oh, perfect.
Can you hear me now? Yeah, I'm sorry.
Yes.
My microphone was giving me trouble. I'm actually going to bring up the website. So I'm trying to think about independent doctors. So I'm going to just take over here. And I have no association with this company. It was something I found over the weekend for independent doctors. This is a very simple, easy to and free solution to use for an audio video platform. Remember, telemedicine's more than just the audio and video. It's the documentation and billing component. The documentation is as you have to have some compliance language. You have to make sure you use that modifier 95, but from an audio and video solution for an independent doctor, this is a very good solution at your fingertips. And one of the reasons that I was on this phone call is because I'm a chief medical informatics officer trying to give you guys some resources right at the front lines.
Thank you, Dan. The next question is, how is this flu different or more serious than, for example, H1N1?
So what we're seeing so far is it's the type of patients it's affecting. So H1N1 really didn't create severe illness in the category of 40s and 50-year-olds. They really, H1N1 had this very weird association with pregnant women. I remember when I was an ICU resident, and we actually had 4 intubated pregnant women who gave birth in the ICU when I was there. This one's really, it's about 1 out of 10 versus 1 out of 5, depending on how you're slicing it. It has a severe illness, meaning they have shortness of breath, lung disease. Some of those people need to be vented, and sadly, some of those people are dying. So that's the big difference. It's the pulmonary complications. It's the age group getting affected. It's people with comorbidities, even hypertension. We're seeing some effects on it. And then there's even some family pockets that we're seeing, and we don't know if there's a genetic relationship, but family pockets of younger people are having it. So certain people in families that are younger are more likely to be affected together, which is why, again, social distancing is very important. It's why we are also not recommending testing people unless you have PPE available. There's no urgency to getting a test done today for a patient who has mild, moderate disease. You expose yourself, you make yourself less available to those patients that need your help. The testing system is going to get up and running, and when it does, we're going to refer those patients to the correct places. They're going to have drive-throughs. They're going to have lots of different options.
Thank you. The next question says, can you please restate the testing capacity over the next 30 days?
This is very fluid. So we have contracts with both national laboratories, and we're in direct contact with the specialized reference laboratories as well. We're being assured that we all have capacity to perform greater than 50,000 tests per day in the next week. These numbers that I've heard vary widely as each individual laboratory across the country brings up testing. So this is a very fluid situation. And the thing to remember is that Abbott, Roche, Luminex, Hologic, Viracor, Eurofins, I mean, ARUP, Mayo, Hackensack, Rutgers, we have access to a tremendous number of laboratories with automated systems that can perform testing. So while the numbers seem very low now for the 327 million people in the United States, we can be rest assured that by the time we look in the middle of April, there will be a significantly greater multiplying effect as these assays come up and running across high complex laboratories across the country.
Thank
And
you.
I would like
the next question is,
I just want to comment. I'm as a person who was a disbeliever in that last week, Nick and I have been talking all weekend. I am a much bigger believer. So I want you to know testing is going to become very, very widely available, very, very, very rapidly. It's not today. That's not the priority. Today is social distancing and keep everybody home. But that's going to change. Even as Wednesday, Thursday, there's a health system I talked to that's going to have a drive-through availability on Thursday, and I believe them.
thank you. The next question is, how susceptible are those who had the flu shot this year? Does the flu shot help prevent or lessen the chance of contracting COVID-19?
No, the flu shot is not protective at all from what we can tell in the early data. Remember, scientific literature is only coming out, as rapidly as it can. What I would say is the people that I am concerned about are people that recently contracted flu. So we still are in flu season. It's only starting to decrease now. And so people who had pulmonary disease and pulmonary injury are probably higher risk from having complications of this disease. Like my own pregnant wife, who I love very much, got influenza just 2 weeks ago, rapid flu positive. I'm very concerned about making sure she's not contracting this. That being said, we're practicing social distancing. My entire company had a soft shutdown today, meaning that every non-essential worker wasn't here. We had some staff pick up their computers. We have less than 10%, and tomorrow we will have 0 workers at the office. So again, as much as you can, encourage social distancing.
Thank you. The next question is, how can an independent physician's office secure N95 respirators for staff?
So that's a great question. And my own practice, when this broke in December, I had hand washing stations put across our entire facility, made sure our practice had it at their facilities. And this is January. I inquired about N95 masks in January. They were on back order because of China. And the biggest places that this country needs to send N95 masks is into our emergency departments and into our ICUs. So most manufacturers are allocating those masks based on what you were requesting previously. So the answer is, I don't have a mechanism for you to get them. I think it's very important that you're getting these people with mild and moderate disease to stay home. If you identify someone as high suspicion with mild moderate disease, ask them to stay home. If you think there's a more likely diagnosis than COVID-19, bring them into the office. But if the most likely diagnosis is that, have them stay home. If they develop severe disease, get them to your local emergency department and make sure you call that local emergency department ahead of time so that they know there's a positive screen coming their way.
Thank you. And the next question is, right now, where could I send a patient for COVID testing in Southern New Jersey?
Great question.
Contact. Yeah. So if you, my cell phone number, I think, is on the presentation. Text me the city you're in. I'll text you back your county phone number for your local Department of Health. They're going to be your best resource to direct you to the use of COVID-19 testing. So just to level set, the CDC criteria right now, and we're getting very conflicting messaging. And I think that testing, we keep repeating the same messaging. Contact your local Department of Health. Tell patients to stay home. But if it's a healthcare worker or a person with one of those 3 sub-criteria, you're going to need to contact your local Department of Health. And then it's important that we follow the regulations that say we're going to notify them that you've identified a person under investigation. So it's not just about testing. We keep hearing that testing will be available. The first thing we need to do is notify the Department of Health that we have a person under investigation. And then they're going to walk you through the screening protocol. Is the patient over 65? Are they immune compromised? Do they have respiratory conditions? What is their health status? And they have nurse practitioners and physicians waiting to take your call. And our experience over the past 2 weeks has been wait times are about 10 to 15 minutes to get on the phone with one of the state's workers in the local Department of Health areas, and certain like Camden County, Cumberland County, they're answering really quickly because they're not as well, Camden's densely populated, but certain like Gloucester and Cumberland and areas, they're not as densely populated, so they're answering quicker.
And we want to emphasize, testing shortage is a problem on today's date. Today, testing shortage is there. That's why we want to keep people home and remember, there is not an urgency getting them tested today. It's about keeping them from panicking and keeping them safe and calming them down right now. Testing is going to ramp up drastically and quickly, and your local health departments are going to start sending news presses out saying that they have drive-throughs and so forth. I was talking to Center State about Thursday. They're going to have an availability. North Jersey's got people coming around faster. Right now in South Jersey, you could use LabCorp, for example, but that's going to be a 5-day turnaround. There could be a health system in 2 days that has an availability that's going to be able to get you testing results maybe 24, 48 hours. I don't think the urgent correct answer. Go ahead. I'm sorry, Nick.
Yeah, Dan, no, don't be sorry. I think it's very fluid, but I keep hearing the same messaging. And LabCorp did an amazing job bringing up the test. I'm one of their largest customers in the country. We love LabCorp. They're a great partner of ours. The issue is that LabCorp cannot collect the sample for you. Do not send this patient to one of the patient service centers. My patient service centers, their patient service centers, Quest patient service centers, we do not have access to test this patient. We cannot collect the sample. And unless you have protective personal equipment in your office and a disease mitigation plan and a disaster recovery plan, we're hearing from practices across the state that they're in self-quarantine for 14 days because the CDC advised them to do so. So just be very cautious. And we've been early on that this is a small business problem in the state of New Jersey. We've been actively identifying this with the governor's office, with the State Department of Health, how urgent it is that our practices, even in large group practices, can ill afford to close their practice in this downturned economy. It is a serious issue. We keep reiterating it, and we hope that the message is loud and clear, and we're expecting some additional messaging around this later today by the State Department of Health.
And these are really great points. The most important thing is to reduce exposure risk and to help as many people as you can right now. Getting someone urgently tested because of their concern and panic for having this disease when they aren't even having symptoms in some of these kinds is not the priority, right? Until the testing system is up and robust, testing asymptomatic people should be out. Symptomatic people with mild moderate should be the secondary priority to getting them into a self-quarantine state.
Thank you. The next question is, for the telemedicine program, do we just set up the doxy.me and run it from the physician's laptops or computers? Can I get more information about this? We are very interested in utilizing the telemedicine aspect of seeing patients. Yeah.
Great question. So yeah, you can just go on here. You can sign up for free, which I don't recommend because it's very slow. If you sign in and you pay, and I think it's $35 pricing, I can actually take you to the website right now for individual providers, $35 a month. You can sign in and you can send a text message to your patient. It works from any mobile device. It will be used from any device that has a camera. The most important feature is the device having a camera. So if your physician has a cell phone with a camera and so forth. Again, I always caution, because this is a technology that's newer, you want to make sure that you do your own review of some compliance stuff. The country is very lenient right now with using different telemedicine programs that they were very reluctant previously to allow, like FaceTime. FaceTime has been coming out. You can even call from your personal cell phone. That will probably not last forever. That is temporarily being approved across the nation. I hope that answers your question.
Thank you. The next question is, what about animals, dogs, cats? Can they be carriers?
At this time, we do not have significant evidence of common household animals transmitting this disease. That is something that I think will come out more and more, but the most recent literature I read on that was probably a week ago, by the way, and that's out of date. But I'm going to answer to that question to the best of my ability.
Thank you. And then we just had one last question here. What about the asymptomatic child who's in your office with COVID? Shouldn't we all assume that patients we see have the disease and all wear N95 respirators?
That is not the current recommendation from the CDC, as well as the State Department of Health, as well as our local departments of health. I think it's very good to be cautious, but caution is with the screening. And the viral shedding from this disease is normally in higher quantities during the febrile state. So people that are within 6 feet that are febrile, that's where you're talking about really needing an N95 mask. An asymptomatic person who may have nasopharyngeal carrying, we have very little evidence that the transmission is happening in large quantities there. We do know that children have a much lower disease severity, so you may want to be more cautious with a febrile child, but an asymptomatic child, no one's recommending to not care for at this point. That's not a me recommendation, that's the country.
Thank you. And what is the website for the telemedicine?
It's actually, I think I'm displaying it right now, correct? Can everybody see it?
Doxy.me.
Yep. Doxy.me is what I'm recommending for an independent practitioner, not a health system. This is something that you can get an audio and video platform up. Remember to talk to your RCM company about place of service 02 and consider using modifier 95.
Thank you. Is temporary FaceTime for mobile devices billable and without a telemedicine platform? Is this HIPAA compliant?
Great question. So, and this is actually much more in my comfort zone as an informaticist. So HIPAA has something called a conduit. So for example, a mailing something is a conduit. So it's HIPAA compliant to put anything in an envelope and ship it off to an address. It's HIPAA compliant to call someone on the phone and have a conversation with a confirmed person. Leaving a voicemail is a different story because leaving the message on a machine has a different set of requirements. So the simple answer is the VA, the Veterans Affairs, has been using FaceTime currently, and they consider it to be a HIPAA conduit and does not require a business association agreement. That being said, the government has come out and very much suspended. I have signed off with my chief compliance officer with my medical group to use any audio video platform that they are able to with the patient. They can tell the patient, hey, this is not HIPAA compliant. Are you comfortable proceeding on this conduit? The patient can say no. The patient can decide to break their own HIPAA. They can tell them anybody anything they want in any atmosphere if they're uncomfortable. So we have a phrase, and I'll actually try to bring up the phrase that we're using for you guys because I think there's going to be a lot more questions on this. And I apologize. I'm going to have to grab my email and send telemedicine. I'm going to bring it up. So this is the phrase that we're using, and specifically you're seeing patients express verbal interest in telemedicine and grant their consent to proceed with the telemedicine interview and exam as outlined below. We are using a phrase to make sure these patients are comfortable before proceeding. So I think it's very important that this patient is informed that, hey, we're using this so that we can keep you safe. And then the reasons that you're using this. I don't think this is something that you should be using like this in this atmosphere for the next 4 years. This is something for us to get through together over the next 4 to 12 weeks together. And I can't imagine anyone's going to come after you. We greenlighted our physicians. I can't personally greenlight this for your own business. That's your business liability, but I can tell you that's what I'm doing with my doctors.
Thank you. And the last question we have here is, can they address a recommendation again for test pricing to payers?
Can you repeat that one more time?
It's pricing for payers. So 2 weeks ago, the CDC test took us 3 hours to perform, and I had to have an extractor, an amplification system, a detection system, a tech that's making $40 to $65 an hour, fully burdened, plus consumables, and a disease management protocol in place. So the cost of testing was well over $100 per patient, well over. In the past week, our IVD manufacturer vendors have all come to the table with the federal government and removed the restriction because an IVD device is the software, the instrument, the reagents, the calibrator, the control, the tech, the medical director, et cetera. That's what makes it a test that's available to deploy. The federal government removed our regulations. I have to give great caution, like I said, about the performance of the testing because we don't have that oversight any longer and we're rushing to meet the need. But with that said, we feel that the cost of testing is going to be somewhere between $20 to $30 per patient. And the federal government has, the Centers for Medicare has come out with a national price point of $51.35. I think if you're in a hospital setting, your cost of testing is probably going to be fully burdened. It's probably going to be in the $55 to $65 range. I think in a commercial reference lab, the highest throughput labs, I'm talking about LabCorp Raritan, right? 100,000, 150,000 patients a day. The economies of scale are tremendous. They're probably in the $20 to $22 cost, maybe $25 cost. So the national set price makes sense for them. When you have your conversations with your managed care payers, I would just be cognizant of total cost of testing, and then the unforeseen costs. So a physician doesn't see patients in one room. They see patients in 5 rooms, and they're going to require gloves for 5 rooms, and they're going to require nasopharyngeal swabs for 5 rooms, and only 1 swab comes back. And the cost of nasopharyngeal swabs due to demand has just jumped. I was on the call last night with somebody, and they told me they're being charged $10 per patient, which we worry about. So I hope that answers your question. You can email me directly if you want to have a longer conversation about establishing a price with your payer. But we just have to be cognizant and cautious of that we're not doing this in conjunction together and following the CMS guidelines.
I'd like to.
Okay, thank you. Sure.
I'd like to add one more thing. So I want to make sure it's clear. The payers have said they're going to pay for telemedicine. That's not guarantee of payment, and I'm not personally guaranteeing that. And I'm just putting a little bit of a hedge on that. That being said, I'm still having our doctors do it because if a patient won't come in or you don't think a patient should go in, that's a chance of a 0 payment versus a possible payment. I also believe that these payers want to make this right in this chaos. They also want to encourage you to keep people in your ambulatory office because that prevents someone from going to an emergency department and possibly infecting them. So I believe that this is going to get paid. That's why I'm supporting it. That's why my organization is supporting it. I also sent the compliance language that my organization is using to the organizers so that they can share it to the audience. I'm not saying that language is perfect. It's what we made rapidly. I want to help independent docs. Literally, my organization entire goal is taking independent docs and keeping them independent. We are a medical service organization that tries to keep independent docs independent. I want to help you. That's why I'm on this phone call. That's what I live and breathe for, giving you guys resources right at the front line for people that are not a part of large health systems.
Thank you, Dan. I will make sure to email that language to all participants today. And I would like to thank you both for taking the time to do this webinar for us today. It was very informative. And as a reminder, all presentation slides are going to be emailed to all participants, as well as a recorded version of this webinar will be available on our website as well. If anyone has any additional questions, please do not hesitate to reach out to the presenters directly. Thank you, everyone attending. I hope you all have a great day, and thank you again, Nick and Dan.
Have a great day, everyone.